Okay, so we're going to go ahead and start with our March provider forum. And we have Jazz Pharmaceuticals, who are going to talk about epilepsy and how they can help. And I believe Greg Hansen was going to open it up and introduce some of his team.
Thanks, Dina. Hello, everyone. My name is Greg Hansen. I am a national account executive for long-term care with Jazz. We bring you Epidiolex, and we'll talk about that in a minute. I'm joined by my counterpart, Johnny Krantz, who I have the southeast part of the U.S., and Johnny has the mid-south portion of the U.S., and he also calls on the National ARC as one of his customers. And we're also joined by Eric Burgess, a PharmD in our medical affairs department. And he's going to discuss Epidiolex and this screening tool, the refractory epilepsy screening tool for Lennox-Gastaut syndrome. So I wanted to spell it out because we're going to call it REST LGS for the rest of the call, but I just want to let you know what that means. And then finally, we're going to end with a non-promotional artistic resource called Unspoken Symphony. It has nothing to do with our product Epidiolex. It's a way for your IDD individuals to express anything they've created visually, and it turns it into a piece of music. And it's a free resource, and we'll end with that. So real quick, in the next 45 minutes, let me just set the tone for what we'll be talking about today. First, I'd like to introduce the type of IDD individual that we'll be focusing on today. That is an adult IDD resident in one of your facilities with epilepsy. And it's someone that may be doing okay, but they're probably not seizure-free. And that's despite trying multiple medications. They may be classified as treatment-resistant epilepsy or refractory epilepsy, and they're not living their best life. So that's who we'd like to have you thinking about. Now, you may say, well, wait a minute, Greg, Epidiolex treats rare epilepsy, and the conditions are Lennox-Gastaut syndrome or LGS, Dravet syndrome, and tubular sclerosis complex or TSC. And you may say, well, we don't have individuals with a rare epilepsy. And what we're going to talk about is how with this new REST LGS tool, your staff, your HCPs and your staff can recognize symptoms in your adult patients with epilepsy and answer 8 simple questions that when they're done, maybe you can identify that certain of your residents, when they go see their epileptologist or their neurologist, you'd like them to see if they have one of these rare conditions. Because once they get a more specific diagnosis than refractory or treatment resistant, that opens your residents up to a whole host of new medications, including Epidiolex, which will allow them to live their best life. And that's what we're all here for. Things like reducing their amount of drop seizures, their ER visits. And we also have some survey data, which Eric will share, on overall behaviors and cognition, how Epidiolex can help improve there as well. One question we get sometimes is, well, how is it that adult residents end up with this non-specific diagnosis? How is it missed? And it's no one's fault. This way to recognize was only developed in the last couple of years with this REST LGS tool. And the tool was not developed by Jazz. It was developed by experts in the field, including epileptologists and neurologists. And so the idea is when this diagnosis is, or when the screener suggests that they may have it, that's something that their neurologist or epileptologist can make that diagnosis. We kind of look at this day to day as the beginning of our relationship with the Florida ARC. We're just so excited to be working with y'all. We will be doing a similar seminar later this month for your caregiver group, and we're participating in your advocacy days coming up in September in Orlando. So please reach out to Dina or me if you're interested in learning more after today's conference. I work with our neuroscience area managers that call on providers in the facilities. So if we can help with a live or a virtual visit to go over Epidiolex or tell them about this REST GS tool, or just to talk about unspoken symphony, we would love to work with y'all to do that. Again, we're just here to help your residents with epilepsy live their best lives. So thank you in advance. Johnny, anything to add?
No, Greg, you did a good job with that. The only thing that I would just add on top of what you already said is just really be cognizant of the individuals that you work with or take care of or care for. Those that have diagnoses such as intractable, refractory, treatment resistant, generalized seizure disorder, and they're continuing to have seizures. Those are red flags for you to really look at and bring up to the consultant pharmacist or the provider to reevaluate, because most often what we see, not all the time, but quite often what we see is when they are diagnosed as treatment resistant, refractory, intractable, generalized seizure disorder, etc. Many times it is Lennox-Gastaut, and it's not, like Greg said, necessarily anybody's fault. It's just the diagnostic criteria has come out in I think it was 2019, so it's fairly new, and a lot of folks just aren't aware of it. And the red flags or the diagnostic criteria for Lennox-Gastaut, as Eric will get into, are multiple seizure types, drop seizures being a large part of that, but multiple seizure types, cognition impairment of any level. It doesn't have to be severe cognition impairment. Often when we say cognition impairment, we instantly think the worst of the worst, but cognition impairment of any level, and an abnormal EEG due to the seizures. Now, this slow spike and wave doesn't necessarily have to be there, especially in the adolescents and adults, because often that can go away as they get older. And Eric, I believe, will get into that. But just wanted to touch on that, and thank you guys for having us on here. And we look forward to working with you in the future. Thank you.
Thanks. And Eric, take it away. Thank you.
Good. Awesome. So can you all hear me, Greg? Everybody else there? You can all hear me pretty well? Cool. All right. Let me go ahead and share my screen.
So I just made you the host.
Okay.
Yeah.
So let's see here. All right. So can we all now see my screen?
Yes.
Good. Okay. So let me. Okay, awesome. So thanks, Greg and Johnny, for opening us up today. It is, really great to be here with you all, and hopefully I can provide some valuable information that you may find helpful. As Greg previously discussed, and Johnny, we'd like to talk today about a few different topics. The first being refractory epilepsy syndromes. This will not be all inclusive, but we will highlight 3 specific examples. I will then move into discussing the REST LGS screening tool in a little further detail, and again, why that may be relevant to you all. And we will finish with some high-level Epidiolex clinical trial data to really see the effect of having a more definitive diagnosis and appropriate treatment in refractory epileptic patients. And again, in this patient population, it's very important to have a more definitive diagnosis when at all possible, really to open the ability for practitioners to prescribe new or indicated therapies, for patients to potentially take part in clinical trials, to link patients and their caregivers to appropriate support group networks, potentially to help alleviate burden on direct support staff and caregivers with greater seizure control And then really the most important, to be able to provide these patients with a greater quality of life with further seizure reduction or potentially seizure freedom, which we do obviously know in this patient population that may be fairly difficult to achieve. But with that being said, let's go ahead and get started. My main goal among these presentations as well is to not bore you all as clinical presentations can get pretty technical. But you can all stop me at any time throughout the presentation, and I will pause at certain areas and ask if there's questions as well. So we will be discussing these 3 syndromes today, and actually working backwards. We'll start with tuberous sclerosis complex, then move on to Dravet syndrome, and finish with Lennox-Gastaut. Again, this is obviously not all encompassing of the potential refractory epilepsy syndromes, but we will discuss these as examples. So approximately 3.4 million people are living with epilepsy in the United States. Of this, roughly 3 million, or the very vast majority, are adults, and 400,000 to 500,000 are children. It is important to note 30% of the total epilepsy population has refractory epilepsy. On the right of the screen here, we have listed the prevalence of TSC, Dravet's, and LGS. These are considered rare diseases affecting a small number of patients, highlighted by different clinical characteristics, but all are severe syndromes and associated with highly treatment refractory epilepsies. So starting with tuberous sclerosis complex, and again, I will try to keep this fairly high level, but if there are more detailed questions, don't hesitate to stop and ask me. And so as I previously stated, TSC is a rare genetic disease, which is characterized by the development of benign tumors in various organs of the body. On the top here, let me go ahead and get the laser pointer. We see that, again, various organs of the body are affected, and those may include the skin, lungs, heart, brain, and kidney. So it affects multiple organ systems, so is not solely a neurological disorder in nature. However, one of the most common manifestations is epilepsy in roughly 80 to 90% of patients. In terms of underlying etiology or cause, TSC has a genetic origin, with 75 to 90% of patients having genetic mutations in the TSC1 and TSC2 genes. Clinical features we see here on the bottom left may be vast, since it is a multi-system condition. This can include heart disorders, again, kidney disorders, very vast. Along with epilepsy, developmental delays and behavioral problems are common. Patients may experience a normal life expectancy with mild symptoms, and neurological manifestations often tend to be the most impairing for these patients. Multiple seizure types may be prevalent, including focal seizures as well as infantile spasms. And TSC is fairly easily diagnosed based on the presence of these benign tumors that are called hamartomas. And as well, we have a genetic test to test for the TSC mutation. Increased risk of mortality in these patients, as we know in most epileptic patients, and especially including SUDEP. And treatment for TSC tends to revolve around treating infantile spasms if they are present with vigabatrin. Additional seizure types may be present, and as we see, everolimus and CBD are also approved to treat TSC-associated seizures. And there are really currently only 3 approved treatments for seizures associated with tuberous sclerosis complex. And moving on to Dravet, so Dravet syndrome is a DEE of infancy onset, typically in those 5 to 8 months old. Again, that is associated with drug-resistant lifelong seizures, with neurological and developmental complications that may include intellectual disability, behavioral concerns, sleep disorders, among others. Etiologically, 70 to 80% of cases arise from a genetic origin with mutations in the SCN1A gene. And Dravet syndrome is, again, characterized by normal development before seizure onset, and development delays become highly apparent by the second year of life. Dravet syndrome typically presents with febrile or afebrile convulsive seizures that tend to be hemiclonic or generalized tonic-clonic seizures in nature. Fever, physical activity, or high ambient temperatures may trigger seizures. Neuromuscular problems are common. And so as we see in this patient population, as well as with really all the syndromes we'll discuss today, there's high caregiver burden just based on the clinical manifestations, the accompanying disorders, behavior disorders, et cetera. And Dravet syndrome patients are at a higher risk of mortality than the general population. And again, the highest cause of mortality in children and adults is SUDEP. And so looking at treatment guidelines, as we see here, there are no US treatment guidelines for Dravet syndrome, but international guidelines do recommend valproate as standard first-line therapy. The remaining alternate therapy line options make up numerous indicated and non-indicated ASMs for Dravet syndrome. And those here we see here include clobazam, cannabidiol, stiripentol, fenfluramine, among others. And going back to why it is important, one of the reasons to be able to provide a definitive diagnosis for these patients with drug-resistant epilepsy is that because in Dravet syndrome, we see here there are actually anti-seizure medications that may worsen the seizures the patients experience, such as those contraindicated therapies we have listed here. With most of these patients, shared decision-making should be utilized for the selection of the best treatment choice for that given patient. And it is important to remember patients with drug-resistant epilepsy are often treated with more than one ASM, and current practice recommendations can be largely empirical as well. So moving on to Lennox-Gastaut, we will learn there is more ambiguity in obtaining a diagnosis, as Greg and Johnny alluded to at the beginning of the presentation. So let's spend a little more time understanding why that is, again, and then we'll move on to the REST LGS tool that can help in diagnosing or identifying some of these patients. So Lennox-Gastaut is a rare disease and a DEE of childhood onset, observed in those 18 months to 8 years of age, which we see historically a peak onset between 3 to 5 years of age. That is, again, associated with drug-resistant lifelong seizures that may change and evolve over time. As we see here on the top left, etiologically, LGS arises from a diverse group of causes, and there is no single biochemical or biological marker for diagnosis, such as in those patients with Dravet's and TSC, in which we are able to test for genetic abnormalities. And this can make diagnosing especially challenging, since this is what we refer to as an electroclinical diagnosis, meaning it is really based on EEG findings as well as presenting symptoms and clinical manifestations. LGS is characterized by multiple seizure types, cognitive impairment, and slow spike and wave complex on EEG. And this is really known as a triad of symptoms in LGS. Seizures are mainly generalized and drop seizures are common. As previously mentioned, drop seizures can lead to injuries of the head and face because of sudden unexpected falls. Tonic seizures are required for diagnosis with at least one additional seizure type. Co-occurring conditions include impaired intellectual functioning, information processing, developmental delays, and behavioral disturbances. Again, there is a high burden of illness that greatly affects caregivers, and there are impacts in almost all aspects of the lives of carers and family members. And mortality risk is greatly increased in patients with LGS, and again, in particularly in relation to SUDEP. So on the left here, we have the causes of LGS, in which are identifiable in roughly to 70 to 80% of the patients. LGS most often develops secondary to an underlying brain pathology, and that may include injury or trauma, infection, tumors, and other congenital abnormalities. Up to 30% of reported LGS patients do not have an identifiable cause. On the right, we have displayed seizure progression in LGS, and we see here that developmental or intellectual impairments are very common early in a patient's life. Patients may experience seizures. However, there may be a delay in the presence of tonic seizures, which is needed for diagnosis. So early on, patients tend to experience more generalized seizures. Again, multiple seizure types, multiple times a day can be severely, severely debilitating in these patients. And as the patient progresses, focal seizures become more common in adolescence and adulthood. So we observe an evolution of the seizure presentation over time in LGS patients. So here we have listed the triad of symptoms, and on the previous slide, I discussed how seizures progress over time. Cognitive impairment and EEG abnormalities also evolve over time in LGS patients. So cognitive impairment historically worsens with increasing age. And again, as Johnny alluded to at the beginning, the hallmark slow spike and wave complex on EEG is more frequently present in young children. And as the patients move into adulthood, adolescence and adults, many no longer exhibit the typical slow spike and wave pattern on their EEG. There are some studies that show the durability of that slow spike and wave complex on EEG has been estimated to be roughly 8 years. However, there's not a lot of clinical data on that. And so as we see, LGS is a syndrome in evolution, which may make a proper diagnosis difficult. And so let's summarize some of the difficulties associated with an early diagnosis, some of which we just discussed. And so again, these triad of symptoms may not all be present at the same time. And so, the slow spike and wave complex may not initially be present in patients who transition to LGS, especially from other epileptic syndromes. So regular reassessment and reevaluation should be occurring. Misdiagnosis is common and early diagnosis can be challenging. As again, there can be a delay of years between a patient's initial seizure and the emergence of the LGS diagnostic triad. The seizure types and EEG features are not static, as we discussed. Seizure types are also not pathognomic to LGS, right? These seizures can occur in many other seizure disorders. So they are not solely belong to these patients with LGS. And again, there is the absence of a single biologic marker, such as in other syndromes that may be genetic in origin and may be more may potentially be easier to diagnose per se. And so that inability to accurately and timely diagnose LGS can lead to numerous challenges with optimizing healthcare in adult patients with Lennox-Gastaut. As we previously reviewed, LGS is a syndrome in evolution. Medical history may not be appropriately transferred from pediatric to adult services, or as patients transition from pediatric provider to adult providers, or even in-home care to home care as well. Patients may no longer tolerate EEGs, or these EEGs again evolve, and co-occurring conditions may develop. So, as I've discussed, there are quite a few challenges and potential obstacles to accurately and timely diagnosing LGS. Often, if the patient is not identified as having LGS in childhood, the healthcare practitioner seeing the patient and as an adult may not consider an LGS diagnosis for patients with refractory epilepsy. And so as we review the proposed treatment algorithm, in summary, first-line treatments for LGS include valproate, plus all of the additional FDA-indicated medications, including CBD as a first-line treatment option. So when treatment options are considered, there is really a large unmet need in the LGS, DS, and TSC populations. These syndromes are associated with significant disability and morbidity across all patients. And many of these patients continue to have seizures despite being treated with a combination of anti-epileptic medications. And this will become really apparent when I just briefly highlight the seizure burden of the patients in our clinical trials at baseline. It really is quite astonishing of how treatment resistant these patients can be. Furthermore, there are a number of ASMs approved for multiple seizure types in epilepsy. However, only a limited amount are specifically FDA approved for these three syndromes, and Epidiolex is approved for these three syndromes. So we know the complex clinical presentation and progression or evolution of Lennox-Gastaut can complicate the accurate diagnosis of this syndrome. As we reviewed, this symptomatic triad evolves over time. But I've also mentioned why it is important at the beginning of the presentation for this patient population, and really any refractory epileptic patient population, to become accurately diagnosed, more definitively diagnosed, and within a timely manner. So again, as Greg discussed, the refractory epilepsy screening tool for LGS was developed by a group of experts to improve both the identification and treatment of patients with LGS. And so let's take a few minutes and review the screening tool, again, which organizations and folks such as yourselves may find useful in evaluating potentially difficult to treat refractory epileptic patients. And so the REST LGS tool is a screening tool created to improve the identification of LGS by both specialists and non-specialists alike, so epileptologists, but also more primary care providers as well. Reliability testing revealed moderate to very good agreement on most diagnostic criteria, and this indicating that experts and non-experts can effectively use the tool. Application of the tool in clinical practice, long-term care / IDD facilities, and group homes may lead to a more timely diagnosis and improved implications for treatment options, prognosis, and formulary inclusion. And the applicability of the REST LGS tool to a wider population of patients with LGS symptoms in both inpatient and outpatient settings may help improve the diagnosis of LGS. And so here we have displayed the REST LGS criteria, which again contains 8 total criteria. Criteria are delineated by 4 major criteria, which really follow the symptomatic triad, as well as 4 minor criteria or features that are suggestive of LGS, which may help to diagnose LGS in the clinical setting. So we see here the major criteria: 2 or more seizure types, seizure onset, younger than 12 years of age, history of the EEG with the slow spike and wave complex, and cognitive impairment since childhood. The minor criteria: persistent seizures despite the use of 2 or more anti-seizure medications, history of VNS, ketogenic diet, or epilepsy surgery. Other EEG abnormalities: paroxysmal fast activity is highly noted in these patients as well. Evidence of seizure-related helmet use or head and face injuries. And so here we have the REST LGS case report form, again listing the 4 major criteria and 4 minor criteria. When a clinician completes the form, the overall score is added, with major criteria contributing a score of 3, and minor criteria contributing a score of 1. And on the bottom left here, we have displayed the likeliness of patients having LGS based on the overall score. And those patients who receive a 12 or higher may be considered to likely have LGS. Those with an 8 to 11 possible to have LGS. And again, this can be used by both experts and non-experts, and has been validated in a retrospective study conducted by Pena Garza and colleagues, in which most patients, as we see here, with confirmed LGS met 3 major criteria and 2 to 3 minor criteria. And important to note, those without LGS, with drug-resistant epilepsy, met only 1 major and 1 to 2 minor criteria. A further validation study of REST LGS was conducted, and this was a retrospective chart review of 100 patients aged 18 and older with drug-resistant epilepsy and IDD who lived in a residential care facility for patients with IDDs. Reviews were performed by 2 primary care providers who were blinded to the prior diagnoses. Primary care providers reviewed patient chart notes from the last 3 visits and used the previously validated REST LGS tool to identify which, if any, of the criteria the patients met. And so here we have the breakdown of the 100 blinded chart reviews, with 26 patients previously having a confirmed diagnosis of LGS and 74 not having a previous confirmed diagnosis of LGS. This was, of course, after unblinding. And so of those patients without a previous diagnosis of LGS, we see that 42 or 57% of patients were likely or possible to have a diagnosis of LGS utilizing the REST LGS screening tool. And so to highlight a few of the author's conclusions and key points, it is important to note the charts reviewed had extensive data missing, which does highlight the challenges associated with diagnosing LGS in adults with IDD. Of the 74 patients who had not previously been diagnosed with LGS, 57% were identified as likely or possible. And those patients should be referred for further diagnostic evaluation at a specialized epilepsy center. The study was limited by a small sample size. However, the REST LGS tool will enable the user to identify potential Lennox-Gastaut syndrome in previously undiagnosed patients with drug-resistant epilepsy, thus opening the door to more specialized care. And so, any questions? I think I've got about 4 or 5 more slides, so I can, even try to get through these, and then we can answer questions as well. So moving on to just really provide a very high level clinical trial data review. So in reviewing study design of our 5 phase 3 clinical trials, these were all randomized, double-blind, placebo-controlled phase 3 clinical trials, which contained a baseline, titration, maintenance, and taper period, with the patient option for enrollment in the open label extension upon trial conclusion. Just to highlight a few key differences among the trial designs, the titration period was 2 weeks longer in the TSC trial due to higher doses being studied in the TSC trials. And in LGS and DS, one trial compared 2 arms and the other trial compared 3 arms. We see a 20 milligram per kilogram per day compared to placebo, and a 10 milligram and 20 milligram per kilogram per day compared to placebo. And the TSC trial studied 3 arms, 25 milligram per kilogram per day and 50 milligram per kilogram per day. And I do have to mention, this is not, the 50 milligram per kilogram per day is not an approved dosage form. And so here we have listed the full inclusion and exclusion criteria in the trial, and we won't review all of this information. However, it is pertinent to know the difference in ages that we have listed here associated with the trials, and the different seizure types that were measured in terms of the primary outcomes. For LGS, we measure the reduction in drop seizures from baseline. In Dravet syndrome, we measure the reduction in convulsive seizures from baseline, and in TSC, we measure the reduction in TSC-associated seizures from baseline. And all patients enrolled were also required to have drug-resistant epilepsy. And so looking at the overall baseline characteristics, here I'd like to emphasize a few key points. Roughly a third of those in the LGS and the Dravet syndrome trials, and a fourth of those individuals in the TSC trial were 18 years of age and older. And this is important to note. And patients were currently on, as we see here, a median of 3 ASMs and had failed a median of 4 to 6 ASMs prior to initiating the clinical trial. Additionally, the vast majority of patients were concomitantly utilizing 2 or more ASMs. And as we see here, the median number of seizures at baseline, so these patients were really highly effective, highly treatment refractory, and high seizure burden. And so moving on to results, here we see the primary efficacy endpoint across all 5 clinical trials for the % reduction from baseline for that specific seizure endpoint of that trial in comparison to placebo. Overall, significant observed reductions from baseline in all active treatment arms ranged from 37% to 49% reductions in their respective baseline seizure type. In LGS study 1, we saw 44% reduction in drop seizures, and in study 2, we saw 37% and 42% reduction in drop seizures based on the dosage given in that arm of the trial. And here we review 50% responder rates, so the percent of patients who achieved at least a 50% reduction in their seizures from baseline. Again, Epidiolex was associated with significantly greater responder rates across all of the studies compared to placebo, which ranged from 36 to 49% responder rates. So we see 44% of the patients achieved at least a 50% reduction in their seizures from baseline, and 36% and 39% in the LGS study 2 as well. We do also have data on 75% responder rates, as well as seizure freedom data in a few individuals throughout the trials. I won't be going over that today, just in due to time constraints. And so I can't go over efficacy data without safety data as well. So here we display the adverse reactions occurring in 10% or more of patients in the clinical trials and more than placebo. The LGS and Dravet syndrome trials have been combined due to their similar trial designs and dosages studied. And again, the TSC trial has been separated due to the higher dosages studied. As we see here, elevated transaminases were common, and this does appear to be a dose-dependent adverse event with greater frequency at higher dosages. We see here in the 20 and 25 milligram per kilogram per day arms, as well as the 50 milligram per kilogram per day arms, compared to the 10 milligram per kilogram per day arms. GI disorders were common, and specifically decreased appetite and diarrhea, which again is more common at higher dosages. Vomiting was noted in the TSC trial. Somnolence and fatigue were common adverse events observed. And additionally, there was an increase in infections observed in the LGS and DS trials, but it is really important to note this patient population is already at an increased risk, as we note the high rates in the placebo arm as well. And with that being said, let me go ahead and stop sharing. And I can go ahead and take any questions if there are. I know we kind of went through a few different topics, very high level. So I'll just open it up to you.
Yeah, let's open it up for questions, and people can unmute themselves or put it in the chat. I know you covered a lot of information.
Yeah.
So I'm just, like I say, if you want to throw out a question, raise a hand, put it in the chat. We do have about 15 more minutes. I'm not seeing anything so far.
One thing I wanted to mention real quick is we didn't mention how easily Epidiolex is available for your individuals with epilepsy. So it's approved Florida, Medicaid and Medicare, and overall throughout the country, it's 90%, 98% available. So it's very easy to get for residents who have one or three diagnoses.
Okay, good. I see some people have unmuted, but I don't see a question yet. Victoria, did you have a question?
No.
Okay.
I would like to cover Unspoken Symphony really quick if there aren't any questions. Can I share my screen?
Yes, let me. And that's something that we are going to cover in detail at our Lunch and Learn in 2 weeks. I did make you the host, though.
Awesome.
You want to just touch on it?
Yeah, and just in case any of you can't be here in a couple weeks, so Unspoken Symphony, it's a great resource. We got it from working with a family of a little girl, Riley, who has Lennox-Gastaut and tuberous sclerosis complex. She's very loved by her family, but is very nonverbal. And basically what we've done is it's a free resource where you take anything that's created visually, could be watercolors, paintings, photographs, upload it through Unspoken Symphony. You can see over here, it says in the corner, see that, it says make a melody. and it comes back down in the form of a song. It's with an MP4 file and sheet music. It even gives anyone who uses it a chance to increase or decrease specific instruments in the song to make it your own. And it's just been a really great resource for nonverbal and really any residents to use to help them express themselves. So again, it's a free resource. Just want to touch on that with you all real quick. And once again, open it up for any questions that you have.
And I know that some people have asked for some information, a copy of the presentation or some handouts, so we will be sending that out later today or tomorrow, just some sort of information. We will be putting this training on our YouTube channel as well.
Yeah, and we unfortunately Eric is not able to share this presentation, but there's a lot of information available at epidiolex.com. And once again, we would love to be invited into your ICFs or IDD group homes to do either a live or a virtual presentation on the things we covered today or different things. We can do those with or without a meal. And it's just a way, again, to help your individuals with epilepsy live their best lives. Johnny, anything to add?
I was just going to say, Greg, real quick, Epidiolex HCP, like healthcareprovider.com. That's the site. It has pretty much everything, most everything that Eric went over today and a lot more. I encourage you to go check that out. Has a lot of good information on there, clinical, some unbranded stuff as well. And it also has a couple of videos of our facilities where we actually do the research and grow the plants. And that's very informative as well if you'd like to see that. But please give us a call and reach out to us if you have any questions or need anything.
I did notice there's a question. Mary asked, is there any information about the effect of Epidiolex on, and then it says ring 20. Mary, could you, I'm at a loss for
Okay,
what
and I
you're
didn't
asking
want
about
to,
there.
oh, okay.
Sorry.
I'm sorry. Can you hear me okay? Okay, so, and I didn't want to specify on just our son, so I apologize, but he has ring 20, a chromosome abnormality. It's not a full trisomy, but he developed seizures at the age of 10 that are now, intractable. And we have tried probably 14 or 15 different anti-epileptic drugs, and he has a VNS and so on and so forth. Everyone's story, I suppose. But I didn't know if Epidiolex, if there have been any studies of the use of Epidiolex on the ring 20 chromosome disorder that leads to seizures often.
Would Eric still be on the call?
Yeah, I'm still here, Johnny. So yeah, thanks, Mary. We do have clinical data on quite a few other syndromes, a lot from our expanded access program. I'm not aware that we had any patients within that expanded access program or or any other clinical data of us utilizing Epidiolex for a ring 20 syndrome. I can look further into that if that is okay with you,
Sure.
and get back to you to see if we do. I have not come across any, but that doesn't mean we haven't had any patients at all treated with ring 20 syndrome.
Okay. Should I leave my contact information in the chat?
Yeah, that'd be great.
Okay. All right. Thank you very much.
Do we have any other questions or comments?
So I believe there's one of what is the current average age of folks using the medication. I don't know that we have that information unless Johnny or Greg you guys are privy to that information that I don't have. I don't know that that internally we have that.
The
Johnny,
average-
were you
Yeah, I
gonna
was
go
going
ahead?
to say, if one ages 1 and up can utilize it. Now, what is the average age?
Yeah.
Again, like Eric said, I will have to find out on what is the average age, but I can tell you 1 year and up. So it's across the board. We do see plenty of adults on it, even upwards into the 60s I've heard of. Folks are living a lot longer now.
Yeah,
So-
and in our clinical trials, again, we had those that were younger than 18 and those that were 18 and over, as I pointed out throughout the trial. So we do have a lot of experience in well, children, adolescents, as well as adults. But to have a current average age, I don't think we have that information.
I do know that the age has increased over time. The early use was a lot with adolescents and peds. And that's why when we realized these adult residents of ICFs and IDDs were out there, that's one thing that led to the creation of this team. And that's why we're talking with you all today, to focus on folks who somehow didn't get diagnosed. They have a general diagnosis, but maybe in your facilities right now, and with a little bit of help with this new tool, the REST LGS tool, and making the epileptologists and neurologists aware of that, we can get them more specific diagnosis and help them out. I just wanted to close our part of the meeting by saying again, thank you, Dina and Ellen, for inviting us on. We're excited to be working with you. Look forward to the next program in a couple of weeks, which will have a little different focus. And look forward to, with your invitations coming in and telling you more about Epidiolex and Unspoken Symphony and the REST LGS tool in your specific facilities where we're invited. So thank you.
Great, we appreciate it so much. All right, thank you.
Thank you.